Hi everyone, good afternoon and welcome to DNX Academy. And today we are going to, so I think everyone can hear me, right? Am I audible? You
Yes,
can
you're
please
audible.
comment. Yes, sir. So today we are going to see the surgical part, so radiological part of this clinical radiological part, where we will be seeing very important clinical scenarios that are commonly asked from in each and every entrance exams. So basically we will be concentrating on conventional imaging today, because in radiology we all know there are different modalities available. Each and every modality is important in radiology, and the most commonly and most widely used modality is a plain X-ray, because in everyday practice you will be writing a lot of emergency X-rays as well as routine X-rays during your OPDs as well as your casualties as well. And then the other thing that we are going to discuss today is about the contrast procedures. In every year, 1 or 2 questions will definitely come from these contrast procedures, and usually plain X-ray will be there. Sometimes image will be there, sometimes the findings will be there in your questions. Other modalities like ultrasound, CT, MRI, and nuclear imaging, we will deal with these modalities in our next class. Okay, so most of the topics will be covered in a question and answer like way, and you will be given the questions and the polls will be there. So please answer the polls so that we can move on fastly. So first I will cover the basics of an X-ray. So this is an X-ray tube, and how an X-ray in an X-ray tube there will be an anode and a cathode. Anode will be positively charged and cathode will be negatively charged. So this is the anode. I won't be going to the depth of the physics, just the basics I will be covering. So what happens is when we give electricity, from the cathode, X-rays will, the electrons will go into the anodes, and that will produce X-rays. And these X-rays will fall, will go into the patient, penetrate the patient, and fall on the imaging plate. So this is the imaging plate, and that is how you will get an X-ray. So this is how an X-ray taken. Considering the modality, the specialty, that is surgery, since it is a class for surgery, the most commonly written X-rays will be chest X-ray as well as X-ray abdomen. So this is how an X-ray abdomen is taken. So first we will move on to see how an X-ray, how to read a plain X-ray abdomen. So this is a plain X-ray abdomen erect. So first of all, what we have to see is we have to look for the gas pattern. Okay, bowel gas pattern. First, you have to look for the fundus gas shadow, whether the fundus gas shadow is seen or not. This is a very important thing in a normal X-ray. Normally, in the left side, you will be able to see the fundus gas shadow here. Okay, this will be the fundus gas shadow. In this X-ray, it is not seen. Then we have to go and search for the small bowel loops. Usually, we all know the small bowel loops are the loops that are centrally located. These centrally located bowel loops will be the small bowel loops. Okay. And usually these bowel loops will be very small. Usually they are less than 3 centimeters in size. Only during the case of acute intestinal obstruction, these loops can enlarge more than 3 centimeters. So generally speaking, it will be less than 3 centimeters in size, and usually they are centrally located. After searching for the small bowel loops, you can go and see the large bowel loops. You know that the large bowel loops are peripherally located like this. This will be the location of cecum. This will be the location of ascending colon. And then this will be the location of the transverse colon, descending colon, sigmoid colon, and then rectum will come here. So first and foremost, you have to look for stomach shadow, small bowel shadow, then large bowel shadows. Okay. After that, you have to look for the organs. If you look carefully, you will be able to see the organs. You know these are the diaphragms. Okay, that is known. And if you see carefully, this is the hepatic margin. So this is the liver. Here we are able to see the shadow of spleen here. This is a spleen. And here the kidneys are not well visualized, but usually the kidneys will be here like that. And here we will be able to see the bladder. Okay, so these are the solid organs. If there are some calcifications, then we will be able to make out this calcification in these organs. Then also we will be able to see the psoas shadows like this. So these are the psoas shadows. So these are some important basic anatomical knowledge that you should know while looking into a plain X-ray abdomen, because generally speaking, we don't rely much on plain X-ray abdomen for making a diagnosis. But if you look carefully, they can give us a clue. They can lead us to a diagnosis. So that is the importance of a plain X-ray. Okay, so we will move forward by seeing one question. So this is a case of a 33-year-old male who presented with abdominal pain to a clinic. So the patient also had a history of anorexia, nausea, and vomiting. Also, he had some episodes of constipation. So the blood pressure of the patient was about 130/80, and his pulse rates were 79. And on your examination, you didn't find any guarding in the abdomen. So as usual, you ordered a plain X-ray chest. This is a plain X-ray chest for the patient. So here I am giving you a plain X-ray chest. So please find out the diagnosis or finding. Please make out the finding and choose the wrong statement regarding this condition. So I will start the poll now. I will start the poll now. So the plain X-ray chest is acquired. Find out the wrong statement about the condition. So in the comment box, can anyone tell me what is the diagnosis or what is the finding that you are seeing for this patient? In the chat box, there are around 42 participants. So can anyone tell me? Okay, one has told chialdity syndrome. Yeah, excellent. So from the clinical history, I have, because I also, that is excellent. So this is a case of chialdity syndrome. So what I am going to tell here is, wait a second. So how did you came to the conclusion of chialdity syndrome? That is the important thing. You have to understand why it is chialdity syndrome, because this is a very common clinical condition. Sometimes the patient may be symptomatic, sometimes the patient may not be symptomatic. So sometimes when you take a routine chest X-ray for some health checkup and all things, you will be able to see this. So how can you confidently call it as chialdity syndrome? Because here the patient is having some pain, and but vitals are stable for this patient. There is no guarding. So this is not a surgical emergency. So you don't immediately need any intervention procedures. So why we are confidently calling it as chialdity syndrome? That you have to understand. Because if you see carefully, the shadow starts from here. If you see carefully, the shadow is starting from here. See, the shadow is starting from here. And we are able to see these vertical lines. So what are these vertical lines? The presence of these vertical lines are the most important thing in making this diagnosis. So can anyone tell me what are these? So these are the hostrations. So these are the hostrations. So the presence of these hostrations, yeah, excellent. So this is presence of these hostrations will tell you that this is a bowel loop. This is not a free air or air under the diaphragm. So if you're still in doubt, then you can go for a CT abdomen, because CT, it will show the bowel loop there. Okay. So there is a difference between chialdity syndrome and chialdity sign. When there is a pain, then we can tell it as chialdity syndrome. And these asymptomatic patients that we routinely diagnose during our health checkup, all these asymptomatic patients can be considered that is chialdity sign. Okay, so I think it is clear. Now moving forward to the another question, I will start the poll again. This is a 43-year-old patient with chronic alcoholic who had severe abdominal pain for 2 hours. So he was brought to the casualty. Again, you ordered a chest X-ray. So what is the diagnosis here? This is a very simple question. I will start the poll again. This is for the first question. Second question we will start. Yes. Again, I am starting the poll. So the patient is a chronic alcoholic patient who developed a severe abdominal pain. So he was brought to the casualty. And here we are taking an X-ray. So excellent, everyone is making the correct answer. So can anyone tell me what is the finding here? These are all basic questions. These are all MBBS level questions. So you can make it a little fast. So what is the finding that you are seeing in this case?
Air under the right dome of diaphragm.
Yeah, excellent. This is there is air under the right dome of diaphragm. That is pneumoperitoneum. So coming to the pneumoperitoneum, it is very easily seen here. See, this is the air under the right dome of diaphragm. This is a small lobe of air, and this is a classical for hollow viscous perforation. So Moving forward, there are in radiology, there are numerous signs for air under the diaphragm. It is better for you to know some of the signs because it's a competitive exam. So which of the following is not a sign in hollow viscous perforation? So generally nowadays, these type of one-word questions are not asked, but just for your knowledge, I'm asking you. I will again relaunch the poll. Every question we will discuss in a poll-like manner. So yeah, this is all these signs are very important. Usually during NEET PG entrance, UG, PG exams, these are asked. Not for super specialty level, they are not asking these type of questions, but just it's better for you to know these signs. Okay, I think everyone know this. Everyone is giving the string of bead signs. So can anyone tell me? Okay, we will discuss that later. I will end the poll right now. So regular sign, falciform ligament sign, cupola sign, all these signs are seen in the case of hollow viscous perforation, but string of bead signs are seen in other conditions. So we will discuss that. So coming to string of beads, there are two string of beads. When it is calcified, that is seen in the case of chronic calcific pancreatitis. And I will show you another string of beads, that's all. So these signs of pneumoperitoneum are developed because this free air will outline various structure. If the free air is outlining the both sides of the bowel, we will get a regular sign or double wall sign because the bowel will be outlined by the air shadow and it will produce this regular sign or double wall sign. If the gas is seen between the bowel loops in the shape of triangle, we will get tilted triangle sign. If the gas is the free air is outlining the falciform ligament, we will get falciform ligament sign. If it is outlining the umbilical ligament, we will get inverted V sign or like that. Wherever the air is going and outlining these structures, we will get different signs. So all these signs are not important, but if you come across to see, because this falciform ligament sign is very commonly seen in the case of gastric perforation, because in gastric perforation a large amount of air will be coming out usually, and this falciform ligament which is near to these structures will get easily outlined, and in CT scan also we will be able to see these different signs. So just keep in mind the name of different signs and just revise it before your exam. This when there is a large foci of air collected in the abdomen, we will get the football sign. All these signs are important. Just need the name. Okay. So coming to another question. So the first session will be completely based on X-rays. As I told you, all these diagnoses, we cannot confidently make any of these diagnoses with X-ray, but for exam purpose and also for our general knowledge, there are some signs that will help us to localize these conditions. Okay, so this is a case of a 45-year-old male who came with a severe diffuse abdominal pain. So again, X-ray chest and abdomen was taken, and from these, which is the following is the most probable diagnosis for this patient. Again, we will start the poll. I will relaunch the poll again. So here, this is a 45-year-old male. Again, a non-specific abdominal pain, severe diffuse abdominal pain. So as usual, the first step, we will take the X-ray. And after seeing this, what is the most probable diagnosis here? So here the confusion is between two options for everyone. Option A and option D, I guess, yeah. Excellent. Some of you have named the sign also. So if you go back and see the X-rays of many of these patients, you will be able to see all these signs. Okay, so I will explain. Here, if you see, this is the ascending colon. Okay, this is the transverse colon. And these loops are small bowel loops. Why I am saying it as small bowel loops? Here we are able to see the valvulae conjunctis. Okay, so we will see what is valvulae conjunctis. Here, this is a sigmoid transverse colon, descending colon, and there is a sudden cutoff of the descending colon. So this is the colon cutoff sign. Okay, so this is a very non-specific sign. What this colon cutoff sign is a very non-specific sign. Whenever there is an inflammatory process going on in the abdomen, there will be an adynamic ileus that is known as a sentinel loop. The bowel which is adjacent to this process, because the tail of pancreas will be usually will be seen like this only. So imagine this as pancreas. So the adjacent bowel loop will undergo paralysis. That is adynamic ileus. So that is not a sentinel loop sign. Usually one loop may be seen in that condition. And because of the inflammation, we will not be able to see the rest of the colon. And this is known as the colon cutoff sign. So this is a case of acute pancreatitis. Many of you have gotten this as correct. But you have to understand that here, the location of the bowel loops. Here, since the inflammatory process is going on like this, because actually in case of pancreatitis, you will be able to see the inflammation tracking through the paracollicutters. There will be, if you read the CT reports, you will be able to see there is fat stranding, there is thickening of anterior, posterior, lateral conal fascia. All these are because of the inflammatory process. This inflammation extending into the fat. So because of this inflammation, there is certain cutoff of the colon, and this is known as the colon cutoff sign. This is a non-specific sign. Wherever the inflammation is there, this sign can be present, but here there is a cutoff of the descending colon. It is usually seen in case of acute pancreatitis. So there are two signs you have to remember. One is the colon cutoff sign, another is the sentinel loop sign. If you are able to see a single adynamic loop, that is known as the sentinel loop sign. And if you are able to see the cutoff of the colon, see here the transverse colon is abruptly cut off because of the inflammation from the pancreas. So we're moving forward. So these are the two important signs you have to remember in plain X-ray. So another question regarding the plain X-ray. This is the case of a 46-year-old male who came to the casualty with the same abdominal pain, constipation, abdominal distension, and you took the X-ray. This is a very classical X-ray taken from Bailey. So which of the following is wrong regarding this patient? I'm asking you which of the following is wrong, because it is very easy for you surgeons to diagnose. So which of the following is wrong? So please go through the 4 options and pick up the wrong option. I will start the poll again. So can anyone comment the classical diagnosis and the signs that are seen in this? The diagnosis is easy. Routine clinical emergency. What sign is characteristically seen here? Can anyone tell? Yeah, small bowel obstruction. Excellent. So what sign also? Okay, here we are able to see multiple dilated small bowel loops. Yeah, step ladder pattern of the bowel. Excellent. Multiple step ladder with air fluid levels. Excellent. So also, if you see that is a known thing for you, I will show you another sign. See these tiny pockets of air loops like this, and these tiny pockets of air loops which are going like this is known as the string of bead sign. Okay, this is the string of bead sign. This is very specific for small bowel obstruction. So everyone know the stepladder sign. That's okay. This we are able to classically see the stepladder sign. Also look for the string of bead sign. Because why it is important, I will tell you. Because we will move on to the next slide. So see, in a dilated small bowel, what happens is there will be the presence of valvulae conjunctivis. Okay, and in between this valvulae, the air will be trapped. In between this valvulae, this air will be trapped, and we will be able to see the string of bead signs in a dilated small bowel loops because of the air which is trapped in between this valvulae conjunctivis. This valvulae conjunctivis is usually seen in case of here the answer for this is 3, because in this option I have given it as this prominent valvulae conjunctivis can be seen distal to the ileal loops. Usually it is seen in the jejunal loops. Okay, most commonly the valvulae conjunctivis is seen in the jejunal loops and in some part of proximal ileal loops. Usually it is not seen distal, because distal to the ileal loops we know the cecum and the large the bowel loops will start. So the wrong statement is this. It is seen proximal to the distal ileal loop, not distal to the ileal loops. Okay, so it is most commonly seen in the jejunal loops. So in ultrasound also we know there we will be able to see dilated bowel loops, and if it is a small bowel, it should be more than 3 centimeter dilated. There will be no effective peristalsis. There we will be able to see the to and fro movement. If you keep the probe there, we will be able to see the to and fro movement of the food particles or whatever the contents that are seen in the bowel loops, but there will be no effective peristalsis, and then we will be able to see the prominent valvulae conjunctivis. These valvulae conjunctivis are usually circumferential. It will be seen like this, and it is commonly seen in the proximal jejunal loops and proximal ileal loops. And sometimes there will be bowel wall thickening more than 3 mm. Okay, so these are the signs that we will get in ultrasound. So now moving forward to other conditions which we can diagnose from this plain X-ray. A 40-year-old came with a constipation and abdominal distension. So again, X-ray abdomen was taken, and here we can easily make the diagnosis. Here also, I am asking you, which of the following is not seen in this patient? Which of the following is wrong? So I will start the poll again. So this is a classical image from a textbook. So which of the following is not seen in this patient? So can anyone tell me what is the diagnosis in chat? This is a classical X-ray. So can anyone tell me what is the diagnosis? Yeah, this is a classical case of sigmoid volvulus. Here we are able to see the coffee bean sign. This is the coffee bean sign, sigmoid volvulus. So what is the close imaging differential for a sigmoid volvulus? That is the next question. That is how you have to understand what is the close imaging differential. What is the close imaging differential diagnosis for a sigmoid volvulus? Yeah, you all are right. This is the coffee bean sign seen in sigmoid volvulus. So what is the close imaging differential diagnosis for sigmoid volvulus? Excellent. This is cecal volvulus. Okay. So imaging wise, we can differentiate between sigmoid volvulus and cecal volvulus. So first we will discuss the answer for this question. In radiology, there are many signs for sigmoid volvulus. All these signs are not very important for you. This Friedman-Dahl sign, this is a sign, this seen in CT, because the 3 points are converging, there will be 3 converging points to the converging lines to a single point. That is known as Friedman-Dahl sign. We can see it in CT also. And when we administer rectal contrast, we will get bird peak sign. That's also correct. And see, the bowel loops will be overlapping liver. Liver will be like this. So this bowel loop is overlapping the liver. So liver overlap sign is also seen. If you carefully see the sigmoid loop, there is no hostration seen in this sigmoid volvulus. See, there is no hostration. Usually hostrations can be seen like this, right? You will be able to see some hostration. There is no hostrations present. So hostrations are predominantly seen in this condition is strong. Sigmoid volvulus is ahostral. In sigmoid volvulus, we will not be able to see any hostra. That is a classical imaging point in sigmoid volvulus. So sigmoid volvulus can be differentiated from cecal volvulus because of its ahostral wall. This is the most important differentiating point. Okay. Also remember, usually sigmoid, since it goes like this, it will go above T10 level. Then this coffee bean sign, just remember Friedman-Dahl sign and bird peak sign. That is not much important, but the most important clinical important point is ahostral walls in sigmoid volvulus. And if you see, this is the case of cecal volvulus. Here, see, one hostra is there, another hostra is there, another hostra is there. Multiple hostra can be seen. At least 1 or 2 hostral markings can be usually seen in case of cecal volvulus. I hope this point is clear. So this is how imaging wise we will differentiate between a sigmoid volvulus and cecal volvulus, because in both of these conditions, these loops will be like dilated and will be seen like this. If you are able to make out the hostra, then it is most probably the cecal volvulus. And also the cecum, just proximal to the cecum, we will be able to see the small bowel. So the small bowel loops will be usually dilated in case of small cecal volvulus. In sigmoid volvulus, usually the small bowel loops will not be dilated. But since because the small bowel loops are seen adjacent to the cecum, in the case of a cecal volvulus, the small bowel loops will be dilated. So these are the 2 important points that we will be using for differentiating a sigmoid volvulus from cecal volvulus. Okay, so I hope this point is clear. I think we can move forward. A 26-year-old female came with severe right-sided abdominal pain. Plain X-ray abdomen was taken. So what is the most probable diagnosis? So we will, I will start the poll again. Yeah, one question is, I will come to it. Okay. Before that, we can do this question. So a 26-year-old female with abdominal pain, I will start the poll. See the X-ray carefully. I think it is easy for you to make the diagnosis. Yeah, I hope everyone is making the correct answer. So here, so everyone is answering C. Okay, that is the correct answer. So where is the calculus in this picture? So where is the calculus? Right medullary calculus. Can you point out the level? Because we need to be more specific. Excellent, the calculus is seen. So consider this as the L5 for around the transverse process of L4 vertebra. Okay, so this is the calculus. Okay, so right medullary calculus can be seen. Okay, L4 level, excellent. Moving forward to the next question. Okay, so this is another same history. A 26-year-old female with a severe right-sided abdominal pain. So again came for the same complaint. X-ray abdomen was taken for this patient. So what is the most probable diagnosis for this patient? Please give your answers. So here, I think everyone is given different options A, B, C, D. Okay, it is not a very we can't be. It is not a classical case. Just for completion's sake, I have put this. So here we have to. What we have to do is we have to make use of different signs, and I will give you a clue. See here, there is a dilated sentinel loop here, and also if you look carefully, here you can see one radio opaque density here. It's very difficult to make out. Just for namesake, I have included this. So this is a case of acute appendicitis. Because of acute inflammation in the right iliac fossa, the cecum and the proximal ascending colon is dilated. This is dilated. And here there is one more adding point. There is a small calculus. This is usually appendicolith. See, there is an appendicolith in right iliac fossa. So this is a case of acute appendicitis. So what I am going to tell you is, it is not easy to for us to make a diagnosis of acute appendicitis with the help of an with the help of an X-ray abdomen. But one important thing that you have to see is you have to look for is the presence of appendicolith. So whenever you are seeing an appendicolith here, a radiopaque shadow in the region of this right iliac fossa, then your mind should go in terms of appendicitis if the patient is having clinical symptoms. Also, there is a dilated sentinel loop here. So only for theory purpose, it's very difficult in practical life for making a diagnosis of acute appendicitis with the help of an X-ray film alone. Just for namesake, I have included. So this is another classical spotter. Usually asked in cases of, usually in the recent time, in the last years, it was, we were discussing this along with our urology questions. So now everything is same. So I have included this also. So 46-year-old female with a recurrent history of hematuria. So they ordered for plain X-ray KUB. There's a classical imaging sign seen in this patient. So what is the diagnosis? Is it a calcified submucosal fibroid or vesical calculus, or is there any distal urinary calculus, or is it a schistosomiasis? There's a classical. So can anyone comment me the name of the sign here? Can anyone tell me the? Yeah, excellent. Fetal skull in bladder. Fetal skull in bladder. See, this is the fetal skull in bladder. So this is a spotter that you have to remember or keep in mind. It is seen in case of schistosomiasis. So can anyone tell me schistosomiasis can lead to which type of bladder cancer? Again, another urology based question. Schistosomiasis can lead into what type of? Yeah, excellent. Squamous cell cancer. All these images, squamous cell cancer images, I have kept it for this CT urogram. So for our next class, we will be discussing it in our next class. So see, this is how, because there will be bladder wall calcification. So this is the bladder wall. See, this is the anterior wall, right lateral wall, left lateral wall. Since there is a calcification involving the right lateral, anterior and left lateral wall, we will be able to see calcification like this in X-ray. So this is a case of schistosomiasis presenting with the fetal head in pelvis appearance. Okay, this is another important X-ray spotter for your exams. So another Important question. This is a 45-year-old female who presented with a severe abdominal pain and abdominal distension. So please identify the wrong component in this condition. So this is a clinical condition. Please identify the wrong component of this condition.